Let me take the opportunity to introduce Gregory Piazza. Dr. Piazza is one of our vascular medicine specialists at Brigham and Women's Hospital and a professor of medicine at Harvard Medical School, and your moderator for the program so I can sit down and have dinner.
Yes,
welcome, Greg.
you can absolutely have dinner. Thank you very much, John. And on behalf of the Board of Directors and as the Education Chair, I welcome all of you and thank you for coming to this session. The first talk did a very nice job of laying the groundwork for the different types of anticoagulation that can lead to bleeding. I'm going to focus on warfarin because despite all of the enthusiasm for the direct oral anticoagulants, there's still a large number of patients that are taking warfarin, and so warfarin isn't going away, and neither is warfarin-associated bleeding. What I'd like to do over the next 15 minutes or so is review the risk factors that are associated and the pathophysiology of warfarin-associated hemorrhage. We're going to highlight the role of a newer way of reversing warfarin-associated bleeding, prothrombin complex concentrate, and then we're going to talk about an overall algorithm for treating bleeding in patients that are taking warfarin. I'm going to start off with a case, okay? This is a 60-year-old man who had a deep vein thrombosis and a pulmonary embolism following ankle surgery in 2007, and then actually suffered a large pulmonary embolism in 2010 that was unprovoked. And he's been on warfarin with an INR goal of 2 to 3, and came in with severe headaches that have been going on for the last several days. He described the headache as sort of unremitting. It was on both sides of his head. It felt like a pressure, and it wasn't like any other headache he'd had before. Over the 24 hours before arriving at medical attention, he actually found it a little bit hard to concentrate and felt lightheaded and just kind of tired and unwell. He tried ibuprofen, he tried acetaminophen, he tried aspirin even, didn't seem to budge the headache, and he did remember that at some point he bumped his head playing racquetball at the club a few weeks earlier. Now here we see his laboratory tests, and the only thing that really stands out here is that his INR was in range, but a little bit on the higher side of the range, 2.9. It was still within the target. And he gets a CAT scan in the emergency department, and he has evidence of blood surrounding his brain. He suffered an intracranial hemorrhage. This is a subdural hematoma. We can see the collections of blood here compressing his brain. And it's not what we want to see in our patients taking warfarin. It's actually what we fear the most. And luckily, with the arrival of the direct oral anticoagulants, we've been able to avoid this with better frequency. The DOACs, as Dr. Ruff showed, are a major advance in anticoagulation in a number of avenues: prevention of stroke in patients with atrial fibrillation, treatment of venous thromboembolism. But as I mentioned, and in the title of my talk, there are still a lot of patients that are taking warfarin. So the first question is, why aren't more patients taking direct oral anticoagulants? If we look at data from 2015, now things might be better now that it's 2019, but not everybody was going home on a direct oral anticoagulant. There's still a good proportion of patients that are getting started on warfarin or are staying on warfarin. Now, some of the reasons for this might be clinician inertia, and there are a number of reasons for a resistance to prescribing direct oral anticoagulants. The clinician might not be as familiar with direct oral anticoagulants. One of the things is warfarin's been around for decades, and when you get used to something for decades, you know its good sides and bad sides. Some patients on warfarin actually get a very nice steady level of their INR between 2 to 3, and it's hard to tell your patient, you know, I'm going to switch you when they have such good control. You can't monitor the direct oral anticoagulants as readily as you can monitor warfarin with the INR, and some patients and some providers feel like they need to know that the blood's thin to that certain level. There's the need for prior approvals, which can be a deterrent for the provider. And then there's always cost associated with newer drugs and co-pays, and that can be an issue. Now, it's not all bad for warfarin. I mean, we have a track record for warfarin that dates back to the 50s and even before. It's very low cost, only $4 a month or $10 for 3 months. The track record is there. Anticoagulation management clinics can help maintain the time and therapeutic range at a very high level, and that's associated with good quality anticoagulation. Pharmacogenomic testing, genetic tests to see how patients metabolize warfarin and how we can dose it, hasn't really panned out, but some people still hold out hope. If patients test at home, sometimes that can lead to better INR management, and some patients actually can go several months without testing their INR. What we're really focusing in is all the disadvantages of warfarin. It has a delayed onset and offset. The dose response is all over the place. You can have a 300-pound man that requires only 2.5 or 5 milligrams of warfarin, and then a 90-pound woman that requires up to 30 milligrams. There's a narrow therapeutic window. Lots of interactions. Some of the food you're eating right now interacts with warfarin, and many drug-drug interactions. Monitoring's a little bit inconvenient for patients and for providers, and there's a real bleeding rate associated with warfarin. This is something that Christian already alluded to, but managing warfarin is not unlike a game of darts. You're actually trying to hit a very narrow bullseye. You're trying to hit an INR range of 2 to 3. If you undershoot, you run the risk of thrombosis. It could be stroke, it could be pulmonary embolism. If you overshoot, you run the risk of bleeding, and the worst thing that we see would be an intracranial hemorrhage. If you look across a number of trials and studies of warfarin for anticoagulation and stroke prevention in atrial fibrillation patients, you can tell your patients that these studies show an average of about a 1 to 2% risk of bleeding per year. More importantly, and I find this study to be very sobering, warfarin is the #1 drug for sending elderly patients to the emergency department with an adverse drug event. It's ahead of insulin, it's ahead of antiplatelet agents. We can see here that of all the drugs that send patients to the hospital for emergency evaluations, warfarin's #1. And part of the reason that has to do, that we see that in elderly patients, is that the risk of bleeding associated with warfarin is much higher in patients who are 75 or older. And that's been shown even with the direct oral anticoagulants as well. So what happens as we get older to our metabolism of drugs? Well, that is very relevant to what happens to patients on warfarin. First of all, there's decreased liver metabolism. That can lead to more bioavailability of drugs like warfarin. Our body composition changes, we lose fat, and if our drugs are distributed more in fats, we can have changes in the availability of these drugs. Some of the enzymes in our liver that process these drugs also change, and then our kidneys don't work as well as they do when we're younger, and if these drugs are metabolized or processed by the kidney, we're going to have higher levels. Polypharmacy is another important consideration with warfarin-associated bleeding. So I mentioned there are drug-drug and drug-food interactions that predispose to or potentiate the effects of warfarin. In the short term, studies have shown that antibiotics are probably the most important drugs to cause a short-term increased risk of warfarin drug reactions. In the long term, it's non-steroidal anti-inflammatory drugs and antiplatelet drugs, like Dr. Ruff was talking about, aspirin, Plavix, some of these other drugs we use to protect stents. Here's another study that looks at polypharmacy and the risk of bleeding. If you're taking warfarin and any one warfarin potentiator, that's going to increase the likelihood of developing major bleeding threefold. If it's warfarin plus aspirin, which we know carries its own risk of bleeding, you're actually increasing it between 4- and 5-fold. The reason we fear warfarin-associated bleeding so much is because of intracranial hemorrhage by and large. We can see that warfarin accounts for a large proportion of intracranial hemorrhage or brain bleeds, and the mortality with a warfarin-associated intracranial hemorrhage is worse than an intracranial hemorrhage that happens due to some other circumstance. What's even perhaps more depressing is you would think that patients suffer intracranial hemorrhage in the setting of having a high INR. It's not actually true. Most of the intracranial hemorrhages that we see on warfarin occur when patients are in the therapeutic range. Now, that's not to say having a high INR isn't a risk. The higher your INR, the more likely you are to have an intracranial hemorrhage. Disability is very high if you have a warfarin-associated intracranial hemorrhage. 90% of warfarin-associated deaths actually relate to intracranial hemorrhage. The level of the INR actually also correlates statistically with your risk of mortality associated with intracranial hemorrhage. So this is a drug that has its benefits, but clearly when it comes to safety, there is this one Achilles heel that really has to do with intracranial hemorrhage. This is a nice study. I put it up because it kind of just shows why warfarin has such a potent effect. This is a mouse model. And what they've done is they've created intracranial bleeding using an enzyme called collagenase. Some of these mice were exposed to warfarin and some of them weren't. The control mice, you can see here, have smaller bleeds than patients on warfarin. In addition, the composition of the bleed, of the intracranial hemorrhage, is different in patients taking warfarin. There's a greater liquid component to the bleed. There's also a greater thrombotic component. That creates a mass effect, and there's more pressure that builds on the brain. There's more damage done to nearby important areas of the brain. There are risk factors associated with warfarin-associated intracranial bleeding that are important for us to keep in mind. We talked about not giving patients aspirin when they don't need to be on it. Patients that are on concomitant antiplatelet agents have an increased risk of bleeding with warfarin. So one of the ways we can mitigate the risk of intracranial hemorrhage is checking to see if they really need to still be on antiplatelet drugs like aspirin. Race and ethnicity can actually play a role. Poor hypertension control. Hypertension itself raises the risk of hemorrhagic stroke, and in the setting of warfarin, it's even increased. Advanced age. And then something we're going to talk a little bit more about is actually the buildup of amyloid, a type of protein in the brain can predispose to bleeding. There's this entity called cerebral amyloidangiopathy that some patients develop over time as they age, where there are deposits around the blood vessels of this protein that actually predispose to bleeding. And the way you see that on this imaging are these sort of punched out black areas. These are areas where there's deposits of this amyloid protein. When you look at it microscopically, amyloid has a very characteristic appearance. If you use a Congo red stain, a special type of stain, you see this apple green sort of birefringence, and that is actually showing you this amyloid protein. You can see it's right around the blood vessel, and it's actually disrupting and interrupting the sort of integrity of the blood vessel, and that sets up for bleeding. Now, someone very famous had cerebral amyloid angiopathy. Ariel Sharon, Israel's 11th prime minister, in 2005 had a mild stroke, and they found out that he had a communication between the top parts of his heart called a patent foramen ovale. And an MRI around that time, which they had done for the stroke, also showed that he had this cerebral amyloid angiopathy. Now, his personal physicians actually recommended that he be on a blood thinner to prevent the risk of another stroke, knowing full well that there was an increased risk of hemorrhage with cerebral amyloid angiopathy, and those physicians were very publicly criticized in the press in Israel. And those critics ended up being right, because in 2006 he had a massive intracerebral hemorrhage and went into a vegetative state. We talked about markers of poor prognosis or markers of increased risk of developing intracranial hemorrhage. Once someone's developed an intracranial hemorrhage on warfarin, there are a number of factors that portend a poor outcome. If the INR isn't corrected quickly, that's just going to be much harder to sort of stem the bleed and correct it. Large volumes of blood create large amounts of pressure on the brain, which is a high-risk situation. Interventricular extension, that's when the blood actually gets into these ventricles in the brain. That can also worsen the pressure. Midline shift is when the pressure actually squishes some of the brain to one side. That's can cause damage to a number of neurological structures. And then if patients have severe neurological deficits at the time of the bleed, the chance to recover them is going to be diminished. So once we diagnose intracranial hemorrhage or other types of bleeding, the most important thing is getting that INR reversed, reversing warfarin. And there are a number of different tools that we have, some that have fallen out of favor. Vitamin K is a slower acting but very important corrective tool for reversing warfarin. It takes 12 to 24 hours, but it gives you sustained reversal. So it's always an important part of the equation in reversing warfarin-associated bleeding. We used to use something called fresh frozen plasma. One of the issues with fresh frozen plasma is blood product. It comes in a lot of volume, so our patients who might be prone to heart failure, it's quite a bit of fluid to give someone, and it can take a lot of time to administer enough FFP to correct the INR. More recently, we've come to use prothrombin complex concentrate, and we'll talk a little bit more about that. It's a low volume, you can give it quickly, and it's really risen in favor as the way to treat warfarin-associated bleeding. And then in the past, we had a recombinant factor 7, which was short-acting. Unfortunately, it has been associated with overshooting the correction and leading to thromboembolic events. This too is not used very frequently. It's also extremely expensive. When we look here at the different techniques for warfarin reversal, we see that the evidence clearly shows that vitamin K is an important part of the algorithm, and then prothrombin complex concentrate is really what we've started to focus on most readily. Here we can see that the INR level before you start giving prothrombin complex concentrate actually relates to warfarin-associated intracranial hemorrhage survival. The amount of time it takes you to correct the INR is very important. If you wait too long to give prothrombin complex concentrate, that's associated with an increased risk of mortality. And here we can see a study that looked at 4-factor prothrombin complex concentrate, the one that we use most frequently, versus fresh frozen plasma for correcting warfarin-associated bleeding. And we can see that intracranial hemorrhage reversal is effectively achieved with that. We can see here that risk of adverse events is reduced when you use prothrombin complex concentrate compared with using fresh frozen plasma. And it's studies like this that have driven guidelines to recommend that we try to use prothrombin complex concentrate first and not rely on our old standby of fresh frozen plasma. This led to FDA approval of prothrombin complex concentrate, which is now recommended as the way that we handle these things. When we look at guidelines, we see that all hospitals managing patients on warfarin should stock 4-factor prothrombin complex concentrate. Emergency anticoagulation reversal in patients with major bleeding should be with this PCC compound and vitamin K, because that gives you the long-term reversal. They don't recommend factor 7, and fresh frozen plasma would only be used if you couldn't get prothrombin complex concentrate. In an overall algorithm, first you want to rapidly initiate sustained warfarin reversal, and that entails giving vitamin K, usually IV. Step 2 is to get your immediate warfarin reversal, and you use 4-factor PCC if you have access to it. One of the most important things about managing warfarin-associated bleeding, in particular intracranial hemorrhage, is to watch that INR. Make sure that it's not starting to rise again. If it is, that means you need to re-administer PCC, because rebleeding can be quite a devastating event, especially in patients who have intracranial hemorrhage who have to go to the operating room. Speaking of the operating room, neurosurgical consultations frequently recommended in patients who suffer intracranial hemorrhage. This data shows a slight trend towards better outcomes if you get neurosurgery involved early. It doesn't mean every patient needs neurosurgery, but having that consultation is very important. Restarting warfarin or some anticoagulant once patients recover from intracranial hemorrhage is actually important as well. The brain study here actually showed that if a patient has an important indication for being on anticoagulation and for some reason they suffer an intracranial hemorrhage, and anticoagulation once they're recovered is not restored, that actually corresponds with a higher risk of death. And here we see an analysis that shows that some weeks after patients recover after an intracranial hemorrhage, you need to have a conversation with the patient and with their other providers, neurosurgeons, neurologists, about whether it's appropriate to restart anticoagulation. Cerebral amyloidangiopathy might be a case where it's not appropriate, but there might be other situations where a patient has a car accident and has intracranial hemorrhage. As long as they're not planning on having frequent car accidents, they should be restarted on anticoagulation. And it is a big folly if they're not started back on it, because that puts them at risk for stroke or recurrent blood clots. One of the important things that we'll hear more about is in patients who have warfarin-associated intracranial hemorrhage, when you're ready to restart anticoagulation, it's a great time to think about a direct oral anticoagulant. They have a much lower risk of intracranial hemorrhage, and that's actually a very tangible thing that we can do in our clinics to protect our patients from future intracranial bleeding. And so with that, I'll just close with saying that warfarin-associated major hemorrhage is a medical emergency requiring immediate reversal of anticoagulation. I'd love to tell you it's going away. It is probably becoming less frequent, but it's still here. 4-factor PCCs replaced fresh frozen plasma and recombinant factor VII as the preferred way to get immediate reversal of warfarin. And then warfarin reversal for major hemorrhage really needs to combine that immediate reversal with that long-term or sustained reversal. Otherwise, you come back with a risk of rebleeding. And with that, I'll thank you very much. And let's see, how did we do? All right, we did well.